Hello, everybody. I am Rebecca Dunsmore Sue, and I am going to get this set up so that um, making sure that Ashley and I are spotlighted. Um, and I'm going to give it like 2 more minutes before we actually start launch into the webinar. But I just wanted to say hello and happy evening. And if you're in Seattle, go Mariners. I may or may not have MLB at bat on my phone right here next to me because we're missing the beginning of the game. But I promise I'll only yelp if they, score a home run or something. I
I thought
promise.
about doing that, but since I was the invited guest, I thought that might not be appropriate.
I forgot I had it on my phone, honestly. It just sort of popped up. They're like, okay, game starting. 0-0-0 outs. I forgot I had put it on my phone the other day when I was doing something else.
Yeah.
All right. Well, as people are pouring in, I'm going to start with introductions so we can get going with this webinar. I know a lot of you watch this afterwards, so I am thrilled to have you here tonight. We are doing a webinar tonight on vulvovaginal atrophy, genitourinary syndrome, and menopause, and beyond. So we're going to talk through some of the more complex things that we see in this space and when you really need to be thinking about other disorders, as well as just sort of reviewing who needs treatment, who can have treatment, all those things. I am thrilled to introduce my guest for this evening. It's Dr. Ashley Fuller, who I have worked with for many, many years. We actually jointly ran sort of a vulvovaginal specialties clinic here in Seattle for a long time. Ashley is now in private practice. I'm with Genève, but it's still an area of really big interest for us, and I think something that we can all use a review of on a regular basis. So Ashley, why don't you tell us a little bit about yourself?
Yeah. Well, thank you for having me. I always get excited about the opportunity to talk about the vulva and
I know.
about good sex, and
Hmm.
especially after menopause, because that seems to be harder sometimes. So I'm excited to be here. So I'm a gynecologist. I like I said, I worked with Becca for a while here in Seattle, and then about a year and a half ago, I started my own practice focusing on menopause, perimenopause, sexual health, and complex vulvovaginal diseases. I really did it because I've been focusing on this for the last couple of years, and I just see so many people struggling with issues in this area. And it really is, to me, an umbrella. Like, you really can't focus on the vulva without talking about the hormones, and the sex always comes into play here. So it's really kind of an umbrella for all these things, and they all kind of go together. So I'm excited to be here to talk about it.
Excellent. And as people may not know, you talk about the vulva all the time. You even have a podcast on the vulva, correct?
Yes. So my colleague Meredith McClure and I, she does the same thing down in Dallas, Texas. We were residents together. We started a podcast earlier this year called Labia Logic, where we talk about all things vulva all the time. So if you're interested in some of that, we talk about sexual pain and vulvar derm things and lumps and bumps, and also like complex vaginitis and things that affect the vulva. So
Excellent. Thank you for doing that. It's
yeah.
it's tough work. All right. So let's start tonight with genitourinary syndrome of menopause because I think that's sort of a big catch-all phrase. It tends to be under-recognized and treated. What are the most common in your practice? What are the most common symptoms you're seeing, and how are you treating those? And just sort of you can even start with a little background on how we got to this terminology.
Sure. I mean, this used to be, I mean, way back in the day, it was called senile vagina, senile vulva, like these like
I'm so
ridiculous
glad we've moved
terms,
on from that.
right?
Thank you.
It's like, what is that? And then it was called vulvovaginal atrophy for a while. And, that has kind of fallen out of favor. And now we call it genitourinary syndrome menopause, to get rid of that atrophy term, which also sounds like not great. And also bring in that urinary part because it definitely is a part of the symptoms of this. But, I think the most common thing people say is dryness. And so when I talk to patients about their dryness, I say, like, is it dryness that you feel walking around? Like, you can go for a bike ride, or, you're like just going throughout your day and you feel like irritated, like almost itchy, dry, or is it just during sex? It could be either. For the sexual part of this, I often hear like feels like sandpaper, can't use enough lube, just feels really irritated. And then there can be urinary symptoms. So like kind of kind of more bladder irritation, feeling more frequency, sometimes pain with urination. But those are kind of the main symptoms I see. And then sexual pain. I didn't say that, right? I mentioned dryness, but definitely sexual pain is one of the most common things I see when we talk about, genitourinary syndrome, menopause.
Yeah. And, treatment wise, do you start straight in with estrogen or do you try some of the moisturizers, lubes, things like that?
Well, I mean, I think lube is great for everything. So, I mean, I never say no to lube.
Yeah.
So I always think people should use lube.
Hmm.
So I always recommend that. I mean, I think there's some great moisturizers out there. I'll be honest, I don't use a ton of them. I mean, I just love vaginal estrogen. Vaginal estrogen is so amazing.
Hmm.
I think it helps a lot of these symptoms and it like reliably helps. Like most
Yeah.
people come back to me and tell me they feel so much better. Um, and I think that, sometimes people think, oh, if you're already on systemic estrogen, you may not need vaginal estrogen, but that is not the case. Most of my patients who are on systemic estrogen also need vaginal estrogen. Um,
Mhm.
so, I definitely do jump to vaginal estrogen pretty immediately when patients come in with these symptoms.
I agree. I often describe it to my patients as like the vagina is at the end of the delta. So it's getting the least of all the things that come through your bloodstream, including
Yeah.
that estrogen you're taking systemically.
Yeah. I mean, I find like in perimenopause or early menopause, or especially when I first start someone on a systemic estrogen, I find that it helps the vagina like for a little while. But I feel like most of my patients, by the time they reach like 57,
Hmm.
58, 59, they definitely need a vaginal estrogen, and maybe even earlier, maybe even in
Hmm.
perimenopause. But I agree. Systemic estrogen isn't really treating the vagina.
Yeah. Can we talk a little bit about modes of estrogen that we use in the vagina? Because I think often, I think all of us have encountered the fact that Vagifem's what's covered.
Right.
And I know you and I probably agree it's our least favorite format.
Yeah. Yeah. I
So
mean,
how do
so
you
I was
counsel on that path? Like, here are what we have. How do you sort of explain that to patients and help them to find good prices?
Yeah. I mean, I think part of the trick of this is knowing how to find the good prices. It's like I think
Hmm.
it's just like part of it, and
This
it's
should
one
not
of
be
the
part
more.
of our job.
I know. Um, so there are four ways four main routes of vaginal estrogen in the vagina. So the ring, the S-ring, which sits at the top of the vagina. I change it every 3 months. A lot of patients love this. It's not one of my personal favorites. I'll tell you why in a minute. But I'm going to go through all of them. Vagifem, which is a tablet, 10 microgram estradiol, on a preloaded applicator that you put up at the top of the vagina. And then there is estrogen cream, so estradiol cream. And then there is Imvexi, which is actually just the same thing as Vagifem. It's estradiol. There's a 4 microgram and a 10 microgram. I generally use the 10 microgram, but people like the 4 microgram also. And it's in a gel cap, so it sticks to the vaginal mucosa a little bit better, so you don't have to put it all the way at the top, and it has an oil base to it. So when people come to me and they are having pain with sex, most of that pain, if that pain is from lower estrogen levels, is at the opening or the vestibule. And the thing is, if you use the S-string or the Vagifem tabs and you put all that estrogen at the top of the vagina, then it doesn't really get to the vestibule as well. So I find that like for at least for sexual pain, I don't find the S-string very helpful at all. In fact, I often see people come to see me who are already on the S-string and have a sexual pain. Um, and same with Vagifem, I don't think it helps as much. So I like the cream because you can put it where you want it. The cream, so you can put it to use your finger. I tell them not to use the applicator. It's gross. It doesn't ever really get clean. But use your finger, go, inside the vagina, rub it around, and then you can put it all on the outside and at that vestibule at the opening. And it's cheap. You can get the cream for like $17 at Mark Cuban's Cost Plus, and you can get it for $30 with a good RX coupon. So for most people, they can get the cream really inexpensively, and it should last like 2 months usually. My second favorite one is the Imvexi, and it's just because it's easier and less messy. But I also think that the formulation, for something about the formulation, the oil base, that for a lot of people really helps. And I've seen patients come to see me who've seen multiple other clinicians, and I just put them on Imvexi from Vagifem or something, and it really makes a huge difference. So I'm sure you've probably seen that too. I think it's
Mhm.
that oil base that it's in. It's just really soothing.
Yeah.
That one's a little harder to get covered by insurance. I actually almost never see that one get covered by insurance, but you can get it through Blink RX for $45 a month, or you can get it through the HRT Club. Um, it's a $99 subscription to the HRT Club. but you can get the starter pack for $52 and you can get refills on the starter pack.
So
So,
neat thing, BlinkRx will do refills on the starter pack too.
oh, really? See, I was wondering about that. Sometimes I get
Yep.
like, yeah. So then it actually is less expensive. So,
Yeah, because the starter pack, when you're using it only twice a week, it lasts 2 months.
yeah.
So they end
If
up
you have it
paying
prescribed in
$45 every
Vexi
two.
before it, there's two prescriptions. There's starter
Yeah.
pack is the 18 tabs, so it's every night for 2 weeks and then twice a week. And then the maintenance packs are just the 8 tabs for once a month. So yes, you can refill the starter packs. So it makes it
Yeah.
much less expensive.
Yeah, no, that's my trick as well because I really
Yeah.
like Invexi. Have you ever, how often or do you ever use some of the other products? So Interosa, Ospemifene, all those things.
Yeah. I don't use aspamifene all that often. It's a serum that you take orally. I've had a hard time getting it covered, and I haven't had a lot of great benefit with it. But I definitely think it could be an option for patients, especially if they don't want to put things in the vagina, which I
Mm,
get. It's like I always tell my patients I want to give them something realistic that they can reliably do at night before they go to bed. And like
right.
if they're like me, we're exhausted at the end of the night, it needs to be easy or it's not going to happen. So I definitely can see that sometimes, doing an applicator and doing all these things, it makes it more hard, make it more difficult. I do use Interosa. So Interosa is DHEA, so it's like a precursor to both estrogen and testosterone, and it changes into estrogen and testosterone in the cells in the vagina. So it doesn't really change your systemic estrogen and testosterone. I will use that if patients come to see me and they are not improving on vaginal estrogen alone, especially for sexual pain. I think
Mm.
adding that testosterone component really makes a difference, especially at that vestibule because it has a lot of testosterone receptors there. Um,
Yeah, and in reality, we convert a lot of estrogen into testosterone in those cells, right?
right. Yeah, it kind of goes both ways, right? So, I
Yeah.
mean, so I definitely think that having testosterone at that vestibule can really make a difference if it's like still really sensitive or being, painful to the touch, with just estrogen by itself.
Hmm.
Intraros is also super hard to get covered by insurance. My trick, I don't know if you have a different trick than me, is Costco, $90. That's the cheapest I've found it.
Yeah, I've had actually decent luck with prior authorizations on Interosa, but that's because
Oh,
I
really?
primarily, so I use it a lot, and this is sort of the next topic, but we talked about all these things and they sound great, and then our patients will go to their breast oncologist who says, you can't use any estrogen. And I say, oh, but yes, you can.
Oh, but yes, you can.
Oh, but yes, you can. So ACOG's stance on this is anyone who has had breast cancer should be considered for vaginal estrogen if they
Yep.
have symptoms. If they're on tamoxifen, there really is no contraindication because any systemic absorption will be blocked by that
Right.
tamoxifen.
Right.
If they're on aromatase inhibitor, they're a little more wishy-washy in their statement that you should try
Right.
other things first, but maybe this is okay.
Right.
I find many oncologists are actually on board nowadays with us using
Yes.
vaginal estrogens, even in
Yep.
aromatase inhibitor patients, because we're
Yes.
using, and I do take care to use the set dose ones. So for my aromatase
Yes.
patients, I use Imvexi, I use Vagifem, I use E-string. I don't use the cream much as I, like you, like the cream and its
Right.
ability to be put anywhere. It's also sort of more randomly dosed.
Yes.
So I
I
stick
agree
with
with
the
that.
things that I know have a fixed dose.
Right.
But I find that oncologists feel really comfortable with Interosa because they have read the studies that say this is a product that is not an estrogen that is being converted inside the cells into estrogen and
Mm.
testosterone, and that the systemic levels are negligible,
Mm-hmm.
which is great. So they're
Right.
much more comfortable with it. So I have had good luck with prior authorizations for our breast cancer patients
Oh,
who are on
interesting.
aromatase inhibitors saying, hey, because of the aromatase inhibitor, there's no systemic blockade of estrogen. This is the safest option as per her oncologist. Da, 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 da.
Mm-hmm.
And actually, I do get coverage that way.
Okay.
For the average patient, I don't. You're right.
Yeah.
You have to
Yeah.
send it somewhere.
Yeah. So it's a nightly
Hmm.
insert. It's kind of oily. It's a
Yeah.
suppository. And it comes with an applicator for every single day, which just seems like so much plastic. I
It's
hate it.
so much plastic. I
Yeah.
know. And it really
Um,
doesn't need an
it
applicator.
doesn't
That's
need
the
it. You could
thing.
even
Like,
use your finger. I mean,
yeah.
it's not that
And half my
hard.
patients just take it out of the applicator, which is so
Yeah.
ridiculous.
Yeah.
Yeah.
So, I mean, I tell patients too, it's a nightly one. So if I also think that like if I usually have them start it for the first month, do it
Mhm.
every night. And if they're doing well, then I'll let them, and it's expensive. They can't get it less than $90 a month. I'll
Yeah.
let them do it every other night. And I've had some patients do fine on that. So
Yeah. No, I do the same thing, or sometimes even like 2 or 3 times a week, depending
Yeah.
on what they're like. If it's for sexual pain, they need it more frequently. But if it's just for sort of the dryness symptoms, then sometimes 2 or 3 times a week is enough.
Yeah, yeah.
Yeah.
And I agree. I mean, always talk to my breast cancer survivors about the safety, but, there was a recent study, I think it was last year, earlier this year, looking
Mhm.
at safety and, even with AIs, it looked like it was very safe.
Yeah.
So I tell patients it's very safe. I think it's somewhat regional. Our oncologists here in Seattle are generally very on board, but I've heard other,
Mhm.
other people in other parts of the country say that none of their oncologists will let the patients take it. And
Yeah.
that's really sad, especially as we have good data to support its safety. But I think I feel more comfortable and patients generally feel more comfortable when we're using a set dose. Because with
Yeah.
a cream, you don't really know how much you're really getting. I don't worry very much in
Mhm.
someone, who doesn't have, an estrogen positive breast cancer, or estrogen positive cancer in general. But I do think it's nice to, not have that concern. So I actually like the Imvexi a lot for that one too, because you're not putting it as deep into the vagina. I don't think you really don't get very much systemic absorption at all, or really any. It's pretty negligible.
Yeah, no, I agree with you there. And
Yeah.
since we're sort of on this topic, I want to sort of talk a little more deeply about sexual pain, especially in the menopausal group. But, so someone came to you, painful sex, we started estrogen, their daytime dryness is gone, but they're still having painful sex.
Yeah.
Where do you take them then?
Yeah, I mean, I always try to take a full evaluation of what's going on. And when I'm evaluating for painful sex, I'm always thinking, well, is it the tissues and the hormones? Is it the pelvic floor, the muscles? Is it the nerves? So I want to kind of
Mhm.
evaluate like what else might be going on. For a lot of patients, if they've been having pain with sex, they get this anticipatory clenching, I call it. So they anticipate that it's going to hurt, and so because it has hurt, and so they
Mhm.
tense up because that's what we do when we think something's going to hurt, and then that causes it to hurt more. And it's really
Yeah.
hard, really flex to overcome. I always want to make them realize it's not like they're doing this to themselves. It's just part of what all of us do. If I'm going to say, I'm going to punch you in the stomach, get ready, you tense up. That's what we do.
Yeah.
And so sometimes they have to unlearn that, especially if they've been having pain for a long time. So pelvic floor physical therapists can also be really, really helpful.
Mhm.
Um, I also want to look and do a good exam and really like determine, is this really, where is their pain? Is it just at the vestibule? Are they having pain elsewhere? Are they tearing every time they have sex?
Mm.
Sometimes with I know we're going to talk about dermatoses and other things this could be, but even just with GSM, I will see sometimes some narrowing of the opening of the vagina, and people will sometimes get little bands anteriorly or posteriorly, mostly posteriorly, that just feel kind of tight. And if they start tearing there, then that tissue, that scar that kind of forms there, is not as strong, and so it kind of will repetitively tear. Estrogen
Mm.
will help it most of the time, but sometimes that little band can just be an issue. And so sometimes patients don't realize they're tearing every time, and that's part of their pain. So definitely want to do a good exam to look at those kinds of things, and then just make sure nothing else is going on. Do they have, are they getting, fissures because they have a yeast infection on the vulva that no one has actually diagnosed, or do they have a skin condition like a lichen sclerosus? Are they having lots of discharge from having like complaints going on in the vagina, things like that. So I definitely want to look at the whole picture and see, is there something else going on? Because it doesn't, estrogen is almost always part of the problem, but it's not always the whole solution, if that makes sense.
Yeah. No, it makes perfect sense. And one of the things I found incredibly helpful is working with women on dilation.
Yeah,
I too send everybody who's having continued pelvic pain to PT. And sometimes it takes 3 to 6 months to get into the good PT, and they want to start something in the meantime. And so I spend a lot of time working through, how do you use a dilator? Because I
yeah.
think when we all trained, we had those awful hard plastic dilators in boxes in our offices,
Oh yeah.
right?
Yeah.
And we were told to hand them to the patient and send them on their way. And it's like,
Right.
well, what do you do with that?
Right.
So I don't know. I think you and I both recommend the same type of dilators. I actually recommend flexible silicone dilators.
Yeah.
I send patients to Sole Source for
Yeah.
those. They have a backstop, first of all, which is really important because you don't want to lose your dilator in the vagina.
No, you don't. You don't.
You don't want to go fishing for that. They're soft, they're malleable, they're less scary than those hard plastic ones. But
Yeah.
I tell patients to get a set of multiple sizes. And, I think a lot of us weren't taught how to dilate.
Yeah.
when we were residents. So I tell my patients, you find the size that fits comfortably but stretches you, but
Sure.
does not cause pain. And you don't just stick it in and out. You actually
Right.
insert the dilator, relax.
Right.
Either sitting or lying down, read a book, 10-15 minutes, just let the pelvic floor and the tissues stretch around that dilator, and
Yep.
then remove it, wash it, and do that as many times a week as you can fit into
Right.
your schedule. And
Yep.
as that gets totally comfortable, you move up a size.
Yeah.
And
Yeah.
then when you get to the size where you're comfortable and you can have sex and you know that the dilator is big enough, I tell them throw it in your shower
Yeah.
and once a week put a little lube on it, stick it in, take it out, make sure everything still works great. If it feels tight, then go back to dilating again. But just, you have to give them a whole plan.
Yeah. No, absolutely. And I think the dilators are super helpful for that brain body connection, like trying to
Hmm.
retrain that brain that not everything that goes in is painful. And also
Right.
for them to realize how the pelvic floor is playing a role. So
Yeah.
if it feels, tender, feels painful, having them be able to relax and see how much that changes their
Hmm.
pain. But I actually use the shower, the shower recommendation too. A patient told me that because it's hard to find time alone to like take
Hmm.
on this endeavor. And I also think there's a little bit of like, oh, I shouldn't have to do this feeling, or like this is
Yeah.
a project. It's always say it's a project, right? And
Hmm.
so, I do think putting it in the shower and being able to put it in, a couple times a week or once a week once they're at a place they want to be. And then I would say you can wash your hair, do all the things, and
Yeah.
as long as you can try to work on relaxing your pelvic floor a little bit while you're doing it, I do think that that makes a difference. And it's something that
Yeah.
you're alone already, and you can do it
Hmm.
more quickly, pretty quickly. So I think that's a good idea.
I do tell patients the one thing I warn against is putting it in standing because then you actually clench your pelvic floor to hold it in.
No, that's true. That's
Don't
true. And
walk
so I say
around.
they can do it in the bath. Yeah. So the
Yeah.
shower, I mean, if they can, have a way they can
Sit.
relax a little bit.
Yeah.
So yeah, they can sit.
Yeah.
Yeah.
Yeah. No, absolutely. And you started to talk about it, and I do want to touch on some of the dermatoses that we see in menopause because I think they're very underrecognized.
Yes.
I think especially for us as gynecologists, we did a decent amount of clinic time, but we weren't really taught the vulva, number one. And number two, a lot of our clinic patients were young. So a
Right.
lot of these dermatoses really do appear with the menopausal transition.
Yes.
Um, the most common of which is lichen sclerosus or lichen sclerosus and atrophicus, as it used to be
Yep.
called. And this is an autoimmune disease of the vulva. It's an autoimmune attack on the vulvar tissues. Love this story. So they did a study back in the 60s where they actually took a piece of lichen sclerosus tissue from the vulva and implanted it on the thigh of a woman and implanted that area of thigh skin onto her vulva. And the tissue that had been removed from the vulva and put on the thigh lost its lichen sclerosus, and the tissue they moved to the vulva gained lichen sclerosus. So there's something localized to the vulva that's going on that we don't fully understand
Right.
in terms of that attack.
Yeah.
But the key that I see is being aware that lichen
Yes.
sclerosus can be developing, especially in the perimenopausal patient, because early lichen
Yes.
sclerosus doesn't look like the textbook. It's not all
Right.
white
No.
and fissured and cracked. It's not this big
Yeah.
plaque.
Yeah.
A lot of early lichen sclerosis, in my experience, is where you start to see that fine red line between the
Mhm.
labia minora and majora, where they're starting to involute
Yeah.
and they're starting to lose their labia. The
Yeah.
labia are getting smaller.
Yeah.
Those tiny little fissures in the posterior,
Yeah.
perianal fissures, those
Yeah.
seem to appear really early in the
Yeah.
process. So if you're starting to see some of these signs, and she's having a lot of itching or having a lot of pain, it's worth a biopsy.
Yeah. I mean, I think, yeah, the way I think about it is like if you see creases between the
Mhm.
labia majora and labia minora, there's some inflammatory thing going on, and that shouldn't be happening. So
Yeah.
it could be yeast, and so those patients often will get
Hmm.
fissures in those creases.
Right.
And it could be lichen sclerosis or lichen sclerosis, but it really is a sign that there's inflammation there. And it's normal for it to be red there a little bit just because of
Uh-huh.
the pressure, but it shouldn't be a crease there.
Right.
And so, yeah,
And
I
it's a
agree.
very distinct red
It
line.
is. It is. Yes. So yeah, I mean, I'm not a huge biopsier. But I look at vulvas all day, every day, and
Hmm.
so I generally will try a steroid treatment, which is the treatment for
Hmm.
lichen sclerosis, and see if that helps. I biopsy if it's not improving, or if I think it's precancerous or cancer, that kind of thing.
Yeah.
But yeah, I mean, I don't ever think there's it's wrong to biopsy. I just would warn what I've experienced in my in my practice is just is if you, I think I was taught in residency, if you don't know what it is, biopsy it. But you know what? So often it just comes back non-specific inflammation, and you're like, well, I could
Yeah.
have told you that. And so I just, sometimes there's like this
Right.
long path report that's like, well, could be, and you're like, okay, well, that
Yeah.
wasn't really all that helpful. So,
That is fair. If
um,
you don't have dedicated GYN pathologists, you get a lot of non-specific reports with biopsy.
yeah, yeah,
No,
yeah,
I agree with that. And then one distinction I'd love for you to talk about is lichen simplex chronicus versus lichen sclerosus, because I think that can be really confusing.
yeah. So yeah, all the lichens are a little bit different. And so lichen simplex chronicus is really just a thickening of the skin because of irritation. So usually the chronic thing is someone who just itches all the time. So they are, sorry, scratching. They're
Hmm.
scratching all the time. That tissue is actually getting inflamed all the time, and it gets almost leathery in appearance.
Hmm.
And it will usually, it's kind of more on the labia majora and less like inside the like labia minora, although you can have it anywhere.
Hmm.
But it really is more of a like a chronic irritation, chronic scratching, chronic kind of disruption of the skin and chronic inflammation that happens. And it's not necessarily autoimmune. It's really just from the scratching. And so for those patients, you need to figure out, is there a reason they're having the itching? Like, do they have a yeast? Do they have,
Hmm.
is it a contact dermatitis? Are they using dial on their vulvas every day? Something like that. But these patients often will say like, oh yeah, I'm scratching all night. I can't sleep. So
Hmm.
you have to stop this itch scratch cycle. And
Yeah.
it's trying to figure out what's kind of the underlying etiology of it, and then using a steroid to stop the inflammation. And for these patients, I just go, I'm not afraid of steroids in the vulva.
No.
You shouldn't be either. Um,
Yes.
but like I just jump in with some clobetasol ointment, and I'll have them use it like every day or twice a day for, a couple weeks until they're, 2, 3 weeks until they feel like they're not itching. And then if
Hmm.
you stop, they get better most of the time. And then if you stop it, it comes back. So I
Hmm.
usually have them kind of continue once or twice a week just to kind of have maintenance, and then they can slowly titrate off of that.
Yeah.
But yeah, so it's not autoimmune, whereas lichen sclerosus is more autoimmune, high, high association with thyroid disease. Like I'd say half my patients
Mhm.
also have a thyroid disease with
Yeah.
it, but definitely related to other autoimmune disorders. I think the thing with lichen sclerosus that's hard is that it's generally there's something about the menopause transition and hormones that are related to this, like you were saying. And I
Hmm.
think now that we don't need to do pap smears after 65, or that's not the standard recommendation, is that so many women are going and not having anyone
Yeah.
ever look at their vulva after
Yeah.
65. And so lichen sclerosus tends to be symptomatic, tends to be itchy or painful, but it isn't always. Like, I think about 7 to 10% of patients who have lichen sclerosus don't have symptoms. Sometimes
Hmm.
I see a patient for an annual and I look at their vulva and I'm like, wow, you have, they have full lichen sclerosus. I mean, do
Right.
you ever feel itchy? Oh, I did. Like a couple years ago, I would feel itchy, but I don't now. And I'm like, oh my
Yeah.
gosh, I'm so glad I looked.
Yeah. I think that's an absolutely critical point. And I actually had the conversation with a patient today who said, well, I don't need PAPs anymore. I have a uterus. So what do I do? I'm like, you go in every year and have somebody look at your vulva
Yes, yes,
because you don't know what else is going on down there. I mean, it's a really hard, I know I'm going to let you talk about mirrors and everything. And I know, but it's a really hard part of our body to examine ourselves. A lot of us really aren't familiar with what we look like at baseline. So don't even
right,
necessarily notice change over time,
right,
especially in someone who might not be sexually active, so isn't having painful sex. They might not even know that these changes are occurring.
right.
And I think you talked a lot about using steroid for lichen simplex chronicus. I want to emphasize for the audience, we use clobetasol ointment for lichen sclerosus. The big difference between the two treatment pathways, because you started the same way, every day or twice a day for
Mhm.
several weeks to sort of calm things down, and then you taper down to a couple times a week. With lichen sclerosus, you do not stop the steroid.
Never stop it,
Eh,
ever.
Never, ever stop the steroid because it will flare right back up and be hard to control. But more importantly, we have good studies that show us that if you continue to use steroid at a periodic interval once or twice a week, that you actually prevent the development of squamous cell carcinoma of the vulva
Yes.
in these patients. So you are actually cancer preventing by using that steroid. I always mix it with estrogen to give them a little, tissue building along with their steroid.
Right.
But I think the other important point, and I've had to have this conversation with many dermatologists, is that, when you put chronic steroid on surface skin, it does thin it and make it
Right.
less resilient. We don't see that same response in vulvar tissues. They're different tissues, and it is
Yeah.
okay to continue to use it, including around the anus if they have
Yeah.
anal symptoms.
It's not like it's a modified mucosal membrane. It's not the same as regular skin. So it is actually pretty steroid resistant. And it's so
Hmm.
common that, patients are told, okay, it looks like you have lichen sclerosus. Use this for just a couple days or a week and then
Yeah.
stop and only use it if you need it because everyone's so scared of it. And I get it,
Yeah.
but that like it really sets people back, that they keep having flares and they're afraid to
Hmm.
use the steroid. So I actually spend a good amount of time talking to patients about, you don't have to be scared of this. This is the standard of care treatment. You're
Hmm.
going to use this. You're going to use it a lot at the beginning, and then you're going to go down to like once to twice a week at minimum for the rest of your life. But it's going to
Right.
prevent more changes on the vulva. It's going to prevent cancer on the vulva. It's going to prevent symptoms. And as long as you keep using it, it will help it. It will actually treat it and put the disease in remission for you.
Yeah. Yeah.
Um,
And I think those are important words to use because I think people don't really realize, like, they feel better. They're like, oh, I can stop. Like, you can never stop.
Never.
That's like
Yeah.
conversation number one.
Yeah.
We are not going to stop this. Can you talk a little bit about some of the rarer beasts that we see?
Sure.
But and with the understanding that, yeah, most of us are not going to see a whole lot of this, but some key features that we can recognize if we're seeing something that we just don't know what's going on.
Yeah. So, I mean, lichen planus is our third lichen, so I'll jump to
Hmm.
that. So, also autoimmune. It presents it presents a little bit differently than lichen sclerosus. One of the biggest things to always think about is lichen planus is vaginal and vulvar, and lichen sclerosus is just vulvar. So, lichen
Yeah.
sclerosus will never go past the hymen. So if
Hmm.
you're seeing disease go past the hymen, it is not lichen sclerosus. Lichen planus can be in the vagina too. And so what can happen with lichen planus is that you can get actually agglutination or adhesions in the vagina because they get active tissue and it gets stuck to itself. So patient comes in and says, I think my vagina is closing up. I mean, it's one thing when the introitus is getting smaller, and that can happen with any of these things,
Hmm.
including GSM a little bit. But if they feel like their vagina, like they can't get past a certain point, then I definitely would want people to look at lichen planus. It also can cause some adhesions around the clitoral hood. Lichen sclerosus it also can cause a lot of ulcerations. It's like it can be erosive. You get erosions, ulcerations, things like that. And they can get because it can be in the vagina, they can get a good amount of discharge with that also.
Yeah.
So, when I think about a patient that comes in and has a bunch of discharge, I always think, and they're postmenopausal, like this could be like an atrophic vaginitis type of thing where they're having inflammation from not enough estrogen.
Hmm.
Kind of, there's like an overlap of desquamative inflammatory vaginitis, which is something we see
Right.
more in our younger patients, but it's the same kind of thing, like kind of this thick, yellow, kind of copious discharge,
Yeah.
not
I
usually
remember the first time I
infectious.
saw DIV, I assumed it was chlamydia. Like, it looks like that.
It
It's
does.
just pussy discharge
Yeah, and lots of it.
and lots of it.
And
Yeah.
it's not, it's pretty sterile. It's not really because of an actual antibiotic or bacteria. It's really just like this inflammation that's happening. And so there
Hmm.
is some overlap, we think, of like erosive lichen planus with that. Like, is that like a precursor? Are they somehow related?
Hmm.
Because they can sometimes present similarly with the discharge and that kind of thing. So,
Right.
um, but yeah, I mean, lichen planus is going to be, you really see more erosions and less of that like stark sheet paper white stuff and more
Hmm.
like you get these
Right.
striae or little kind of white, like
Hmm.
kind of cobweb looking things on the edges of the labia, and then more erosions.
Yeah, and when I'm seeing somebody who has some of these complaints, I also ask about their mouth because erosive
Yes,
lichen
always.
planus often when in the vagina is also in the mouth, so they get frequent mouth ulcers, and you can actually look at their gums and see the cobwebbies
Yep.
there too. Or I've had patients sent to me from dentists who say,
Yes.
"You have lichen
Like,
planus in your mouth. Do
yeah.
you have any vaginal symptoms?" They're like, "Oh yeah."
Yeah. 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 So yeah,
Um,
it's very common to have lichen planus in the mouth also.
yeah,
So,
yeah.
and they really can have it in any mucosal membrane. It can be in esophagus, and the patient has it in the esophagus, and it can
Hmm.
be really bad.
Yeah, I can. I can. The other thing I wanted to ask you about, which I didn't pre-warn you, but I know you can talk about it at length, is some of what you see in terms of like yeast on the vulva,
Mhm.
and what are we missing in terms of yeast in the vulva? Like we all know about Candida albicans and how to
Yeah.
treat that and what that looks like, but what are some of the more unusual things that you're seeing?
Yeah, I mean, I think that it's pretty common for especially postmenopausal patients to get some yeast on the vulva. And so I think we always think like, oh, yeast infections are vaginal and they're big, like the cottage cheese discharge. And so patients don't always think that's what this is, but you could actually get like a skin yeast infection just on the
Hmm.
vulva. And I think when we as clinicians were taught how to swab for this, or I know in a lot of places, patients are just given a swab and told to swab themselves, it's in
Hmm.
the vagina. And so if they only have like itching on the outside and we're swabbing the inside, you could actually miss this. So sometimes we'll see patients actually just have vulvar, candida, maybe even candida albicans. It just hasn't been picked up because no one's really actually swabbing there. But in
Hmm.
terms of like what's hard about it, I mean, you can have more rare yeast. So we usually with yeast, we see Candida albicans. Albicans is becoming a little bit more resistant to azoles. So, we give diflucan out like candy a little bit. And I'm not,
Hmm.
I do like the fluconazole, but it's definitely, we are getting more azole resistance. And
Yeah.
so sometimes I'll see patients with Candida albicans that is resistant. Let's see Candida glabrata, so kind of a different beast. High likelihood of being azole resistant. So treating with nystatin or other non azole type
Hmm.
options.
Hmm.
Brexafemme used to be on the market, is still not on the market. I don't know if it's ever going to come back. It was shut down after GlaxoSmithKline actually bought the medication, but it was a manufacturing line contamination, and that was like almost 2 years ago now. So I don't know
Yeah, they
if we're
haven't,
ever going to
it
see that.
hasn't come back.
No, it hasn't. Sometimes I'll use like some like amphotericin B. Like there's some other things, but it's more
Right.
complex. So I think my biggest thing to say about the vulva and yeast is to swab the vulva if you think that they're having a lot of itching. Swab it where they're having the most irritation, and most
Hmm.
time it's going to be albicans. I do like some of the like there's a nice nystatin triamcinolone ointment that you can get. That's prescription, usually covered
Oh,
well by insurance. Yeah, and I like it because it's
excellent.
an
That's a good
ointment.
hint. Yeah.
Yeah, and so it's mycolog, I think it's called. And so
Yeah,
it's
especially for the glabrata, because glabrata, I find, you and I both had this experience. You can treat it,
yeah,
and it just causes so much inflammation that oftentimes they're still symptomatic, even though the glabrata is gone.
right. And it's one of those things of like, well, there's kind of two camps. Either that the Gibraltar is really not the problem, it doesn't actually cause all the inflammation, or I kind of am more in the camp of like, well, once you've had it, it really messes up with the immune system in those cells and really upregulates the inflammatory marker. So even once you get rid of it, the symptoms don't always improve. It's complex for sure.
Yeah.
Yeah.
All right. Last question for you before we open up to Q&A. So folks
Yeah.
who are listening in, if you have questions that have been brought up by all of this, please feel free to put them in the chat or the Q&A button. We'll look at them both and answer whatever we can. But last question for you, Ashley. Okay, so someone's come to their regular gynecologist. They're just not, the gynecologist is sort of frustrated. They're not sure what they're looking at. How do you find someone who might have more expertise in vulvar medicine?
Yeah. I mean, I think it's hard. There's definitely not enough of us that do a lot of vulva stuff. I think I'm hoping that we're teaching residents more about it. It's not something
Mhm.
I learned a ton about in residency, even though I do
Right.
it, full time now. There, ISSVD, International Society for the Study of Vulva Vaginal Disease, does have a website that lists practitioners on it. There are some good vulvar dermatologists that will do a fair amount of this also. Um,
Hmm.
and then ISWISH, International Society for the Study of Women's Sexual Health, does have a provider linked to on their Persela website. There's a lot of different kind of practitioners, so it can also be pelvic floor PTs and sex therapists. So you have to kind of look through it on websites and see what people
Right.
specialize in. But I think those are good resources. Um, and I definitely think that those are also good if you are someone who wants to learn more about vulvar health and
Mm.
how to help patients with these issues. I mean, even as a gynecologist, like I've learned so much from these two organizations. I think those are good places to start. They have really good conferences, and Ishwish has a great fall course that they do a lot of teaching for this stuff.
Yeah. We do have a question. Would you comment on compounded testosterone for GSM? Helpful, not a fan of compounded meds, so curious about that versus Interosa. I'm going to give a little disclaimer. In general, we don't recommend compounded meds. You're absolutely right. The vulva is one of those places where I flex a little bit, and I'm a pretty stringent, no compounding kind of person. And the reason is there just aren't a lot of things generated in appropriate bases to be put on the vulva. If I could have them use just a tiny little bit of testim on their vulva, I wouldn't have to compound, but that's an alcohol base. You cannot put that down there. So we're a little bit less served in this
Mhm.
area. But I think starting with Interos is a good idea. What do you do from there, Ashley?
I mean, I do compound estrogen testosterone for the vestibule. I think it is really helpful. I often give
Mhm.
patients the option, like, do you want to use estrogen testosterone cream and rub it at the vestibule, or do you want to use DHEA, the Interosa? I think
Mhm.
I talked about cost differences and application differences. I mean, I compound a lot of stuff for the vulva for like just kind of vulvodynia and like other types of vestibulodynia, like a lot of neuromodulators because they just don't
Mhm.
exist
Right.
in the world in bases that the vulva can use. So I I compound quite a bit. I try not to compound hormones all that often because I
Yeah.
don't like the variability in dosing that we get.
Yeah.
So I personally still, if I do use estrogen testosterone on the vulva, I do the estrogen, asking how to write it. I do estradiol 0.01%, and my testosterone's like a 0.1%. It's pretty low. I know Becca sometimes will do a 0.5%. You could use it less
Mhm.
often then, but I usually have been
Mhm.
using it nightly at the 0.1%. But I actually check a testosterone level before I start them, and then I'll check it again after they start it, like
Mhm.
because every once in a while I have somebody that has it's like 800, and I don't think they're
Yeah.
using that much of it. I think it's
Right.
just that it's like it has
Bad
a variable
compounding.
dose because it's
Yeah.
compounded. And even though I
Right.
use like a really good, like,
Mhm.
a large compounding pharmacy, centralized compounding pharmacy, I just think it introduces variability, but I still think and I still do it.
Yeah. I agree with you there. When I use it on the vulva, in theory, when you're putting it on the vestibule, you're really not going to absorb anything systemically. But because compounding doses are so variable, especially with hormones, and I don't really know why so variable with hormones, but they really
Oh,
are. They just, I check as well. I check before just to make sure they're not already really high, and then I
uh-huh.
check usually at 3 and 6 months.
Yeah.
And then just annually after that, if they're continuing on it. We also got a question about, is if the alcohol-based testosterone gel is irritating on thigh or arm skin, can we use a
Mhm.
compounded cream? I can't recommend it. Again, so variable in the
Mhm.
dosing, and it's
Yeah.
really hard to be sure how much you're giving them. Um, yeah, it seems easier, but when you've looked at, there are good investigative journalist pieces where they sent the same prescription to 8 different compounding pharmacies and got 8 different doses back. Most of them varied within like 20% of what was written, but like one was in like 90% stronger than what was written. So you just have to be very cautious when you're compounding for systemic use, especially. I'm a little more comfortable with the vulva because we're using very small amounts in a very limited space and we're checking.
Yeah. I mean, ultimately, I mean, most of the patients do fine with testosterone gel, like the generic Testim for
Mhm.
systemic. This isn't for the vulva, but for
Yeah.
systemic testosterone. I have some patients tell me that has a really strong male like cologne smell. Not everyone has told me that, but some people feel like it has an odor to it.
Hmm.
It's just harder. Like the other like androgel, the other ones are pumps. It's hard to get a good like
Hmm.
a dose. I mean, ultimately, like it'd be really nice just to have a testosterone patch, like an actual
Wouldn't
female
that be
dosed
awesome?
product. So, I mean, I know that you
Like, you
can
mean like the
I
existing product that is available in other countries that
right,
is been proven
Australia
to be
and the
safe and
UK.
effective for
Yeah.
women at the right dose?
Yes, that. So,
That thing.
yeah, I
Yeah.
mean, so I know that people are looking at it, and so hopefully at some point, I'm not holding my breath here, but
Yeah, I'm not holding my breath on this current administration worrying about
no,
women's sexual function.
no.
Sorry.
So yeah, I mean, it's harder. I mean, I think it's all shared decision making. I'm not a
Hmm.
never use compounded testosterone person. I usually steer away from it quite a bit for systemic testosterone. But if patient like is just having tons of irritation with it, then and they really are committed to, they
Hmm.
feel like they want to try it for libido, and they, understand that there's some more variability and it's actually more expensive, and I will do
Hmm.
it. But it's just I usually talk through like why it's not my favorite and that
Hmm.
kind of stuff.
Yeah. And I will say for folks for whom cost is an issue or access to the testosterone, the Testim or the androgel that, we use, I know a lot of pharmacies are getting fussy about us prescribing a 32 box, which is actually 300 days of a controlled substance.
Oh,
HRT Club is a really awesome choice for
that's what I use
testosterone.
all the time now. Yeah.
Yeah, so again, it's a $99 subscription, but they send out Androgel or Testim, and they send it out in monthly supplies. And what their Testim's like $18 a month, right?
Yeah.
Something
Yeah.
like that. It's really,
It's
really, really affordable.
$120 for like the
Right.
whole 300, yeah, 30
Yeah.
pads, 30 tubes, yeah.
Um, Can you comment on recurrent UTIs with GSM and any, if any particular estradiol for vaginal root is better for that?
I think any of them will be beneficial. I still think that like getting the estrogen closer to the urethra makes a little bit of a difference, but really it's about like even estrogen helps this because it's really about changing the
Mhm.
bladder mucosa and
Yeah.
having estrogen around there. So really any of them will work.
Yeah, and
So
I often use estering in people who might have maybe frequent UTIs, but also have maybe a little bit of urge or stress incontinence,
yeah,
because I think having
yeah,
that E string sitting right up under there, it's a slight pessary.
yeah,
So it can
yeah,
be a little bit helpful there. So
yeah,
I find that's one of the main uses I have for E-string, if someone who's
yeah,
not really complaining of sexual pain, but it's more urinary in
yeah,
nature. But
yeah.
I often, anyone I give E-string, I always hand them, I give them one tube of estrogen cream too, and they can
Uh-huh.
put just a little around the urethra or a little in the
Yeah,
vestibule on the
yeah,
outside. You can mix those two together, and I
yeah,
find that really helpful.
yeah. I always think it's good to remember that like these patients who haven't had any penetrative sex for a long time and everything is painful at that opening, you give them estering, it's like kind of impossible for them.
Yeah.
So to get it in, to get it out. And so that's the other reason I don't like it that much. Most like patients have pain and then they
Yeah.
get this big bulky ring and they're like, what am I supposed to do with this?
I know. You know what's funny? Uh, I had one patient at our shared practice that was like 87, and the only reason she couldn't do her S string is because she had such bad arthritis. So she just
Yeah,
came in every 3 months and we changed it for her.
yeah, yeah.
But
I
she
used to do
loved it
that.
otherwise.
Yeah, yeah. It can be,
Um,
some people love it. Yeah.
yeah. Somebody is asking, is Tibolone used in the US and does it help with GSM? We don't have Tibolone in the US,
I
so
don't, yeah.
can't comment. Never used it. Yeah.
Yeah.
It's just not available. And I'm trying to remember some of the data I've seen on it. It does have some additional risks when compared to estradiol, but off the top of my head, I don't remember because it's just never come up for me.
Yeah, I'd have to look at the data again to remember.
Yeah, no, we've never had access to that. It's never gained approval in the US. All right. I think we are out of questions, my friend. Great questions, by the way, everybody. And thank you
Yes,
all
very
so
good.
much for attending on a baseball night. You
Yeah,
can all go watch your baseball game now.
yeah.
And we'll get
I will say, I don't mean to interrupt you, but the question about UTI, I don't feel like I said that enough, is that like
uh
vaginal estrogen reduces recurrent UTIs, and
Yes.
recurrent UTIs can kill women. Like
Yes.
urosepsis is not nothing. You know this.
Sepsis is absolutely not nothing. I just got my mother-in-law home from a 3-week hospitalization. So,
Yes, yes. So I didn't mean to
urosepsis is
interrupt
not
you
nothing.
from what you're saying, but I just wanted to mention that because I didn't
Yeah.
mention it in my like symptoms that you normally see with GSM. But that definitely, I mean, when we are postmenopausal, the angle of the urethra, the bladder mucosa without estrogen, it changes
Mhm.
how easy it is for E. coli and other fecal bacteria to get up in there and cause urinary tract infections, and women can get really sick from them. So
Yeah.
it's vaginal estrogen is super
Plus,
helpful
it's
for
just
that.
uncomfortable and annoying. And,
Yeah,
it also limits sexual function because people, women are not having sex because they're afraid to get a UTI.
absolutely.
So,
Yeah,
vaginal estrogen is wonderful for that.
yeah.
Somebody commented in the comments that Susan Davis just did a great video about this on Insta. If anyone is not following Professor Susan Davis, please go and follow her right now. She is basically the world's expert on testosterone physiology in women, but also just in general on menopausal hormone therapy. She is no nonsense. She is really lovely, and just her videos they've taught me things that I didn't even know. And she knows the data inside and out. And
Mhm.
she is actually currently running studies on testosterone use in women that hopefully will publish in early 2026. So we may have more um, data. Yeah, and she did just do one about Tibolone. You're correct because they do have it in Australia where she is based. So definitely follow Professor Susan. It's Professor Susan Davis on Instagram because in the British system, professor is the honorific you use. So thank you everybody for coming tonight. This was a wonderful session. Ashley, as always, I love talking to you. So
It
thank
was
you for
fun.
talking Volvo with me all night.
Anytime.
And we will get this up on the internet as soon as possible. But everyone go and have a wonderful evening. Good night.
Bye. Go Mariners.